Uwe said he was going to be here, so I'm anticipating he will be whenever he gets here. And I was really excited to have him because he literally wrote the book on chronic pain and cannabis, and then went on to, I don't know if you guys are familiar with this book that he did, but it's called Cannabis for Chronic Pain Relief, a dual guide for patients and clinicians. And so this book, have you seen this, Debbie?
No, I haven't.
Okay, so this is really cool because it actually has the protocols and the algorithms and the dosing guidelines. And oh, there he is. There he is. I was just talking about your book. Hopefully you'll speak to this book a little bit as well, because this is not just for clinicians, it's also for patients who want to treat themselves. So good to see you, Dr. Love.
Hey, how are you?
Good. Everyone. So let's just get started here. Did everybody get a chance? I know Debbie said that she has gone through this article with fine-tooth comb and has notes, so she'll be ready to discuss all of this with us. Yes, okay. So the title of this article is Cannabinoids in Chronic Pain Management, a review of the history, efficacy, applications, and risks. And this article was published in 2025 this year, so I thought it was a good one for us to go through. And it was actually, the review was done out of Phoenix. So that's where you're at, Debbie. So I'm sure that there was some connection there for you as well. So let's dive in. What did you guys think?
For me, it was it was just a confirmation of the work we did to publish the book. I appreciate that more and more academic groups are coming together to really sort of like flesh out the context of all that's available to make more informed and discerning decision in the clinic, especially in the treatment context of chronic pain, which is so poorly served by orthodox treatment methodologies. And I think that this article, as well as most others, are actually a bit too conservative, considering the safety profile, and the other clinical applications that are already FDA approved. And so with that caveat, it's nice to see more and more of those, and that's sort of like my intro comment to that particular study.
And I agree with that. That is a good, the more I've been doing this for 10 years now, and studying chronic pain and working for myself and with other clients, and more and more we see the real true facts about it. But I also think it's important to point out that it depends on the type of pain that you're talking about and what we're finding in efficacy. And there's a lot of things that aren't considered in this study that I think should be considered, and it's just they're not there yet.
For example?
Terpenes and the role that they play.
They're in this book.
Yes, I know. Don't know that book, but I know about terpenes and the role that they play, because once you introduce terpenes and fully understand the specific terpenes that you need to either manage chronic pain, basing on what type it is, and then inflammation, it just improves the viability of what you're going to see for results.
Debbie has a good point, in terms of talking about what's missing. One of the biggest outstanding things that's missing is the endocannabinoid system and its involvement in pain processing in general. So this is really not about cannabis. This is really about the endocannabinoid system and how we can modulate various components of the endocannabinoid system to mitigate the many forms of chronic pain and the different patient populations in which they manifest. And so even if we don't talk about cannabis or cannabinoid-based therapeutics, there's so many things we can do to improve endocannabinoid signaling and to undo suboptimal and dysfunctional endocannabinoid signaling, without ever having to talk about cannabis. So that to me is the biggest thing that's missing out of 99.9% of the studies looking at chronic pain and endocannabinoid research or cannabinoid research.
Yeah, I'm glad you brought that up, Uwe, because in your book, you list your protocols, and you have THC dominant protocols, balanced THC CBD protocols, CBD dominant protocols, and then you have the EC BOEM protocols. And part of that, you list not only terpenes, but you talk about the lipidome, so, the healthy fats. You talk about engaging the microbiome through foods, and then you also, the lactobacillus and different, good bacteria. And then you talk about the mind-body medicine, which you include yoga, acupuncture, osteopathic techniques, and exercise.
And all of them are in the book because there is studies to support that. We didn't include anything that didn't have enough studies to warrant inclusion into the specific protocols. And that's why I'm feeling confident in saying what's missing out of the discussion is, the state of endocannabinoid tone in chronic pain population can be addressed in so many different ways. And in fact, the more angles, the more approaches we take and compile a healthcare regimen, if you will, the higher the chances of making inroads that last a lot longer than the effects of a particular drug, including cannabinoids.
I think it's important to also state here, though, that I was doing all of those other things for the endocannabinoid system, even though I didn't know it existed at the time. But I was looking at diet, using flavonoids and stuff like that, terpenes, without even knowing that I was aware of that, doing all that. But it wasn't until I started engaging my ECS with cannabinoids, because I believe my ECS was completely dysregulated. And so it took adding those cannabinoids back in to bring that regulation back together. And now I'm 10 years in. I was at a chronic pain of 10 when I started on 240 milligrams a day of OxyContin. Just let that set in for a minute. And now I'm at 0 OxyContin, and I'm at 0 pain level. And that didn't happen overnight. That took a long threshold. And that's the other thing that I see that's missing from all of these studies, is understanding that it doesn't cure your pain. It just puts your ECS back into balance and allows you to keep it there. What I consume today is far less than what I needed to consume when I was trying to taper off of opiates and to manage my pain. And so now my consumption is much smaller, but if I don't consume, my pain will raise its head.
Absolutely. And you're talking so beautifully about the different manifestation of different intensities of patients suffering from chronic pain, from very mild to extreme long-term 20, 30, 40-year type of suffering. And of course, on that scale, depends on where you fall, your endocannabinoid tone is going to be directly reflective of that. And so patients that are on the more severe end, they definitely benefit from cannabinoid-based therapeutics. In fact, they would benefit from THC dominant protocols and on higher dose protocols titrated to effect to balance that fine line between a therapeutic and an adverse effects until that optimal spot is achieved. And then over time, you can always titrate back to less and less and bring more of the other elements to play, while somebody who has an occasional minor chronic pain, they can perhaps start with a CBD protocol or with modulators of the endocannabinoid domain. For them, that's enough. And so again, endocannabinoid medicine is about finding the ideal approach for each individual patient, because we're all different. But the one thing I wanted to add to that is our younger selves bounce back from acute and chronic things much faster than our older selves. And part of that is because when we're exposed to chronic toxins in the environment, when we have a poor diet over many, many, many years, or when we have acute or chronic conditions stressing the endocannabinoid system, over time, our older selves, and they are the numbers that are out there. We're looking at about half of the expression of endocannabinoid receptor sites when we get older compared to when we're younger. Again, that unfolds on a spectrum depending on how many stresses we are exposed to, but we don't code for as many cannabinoid receptors as we're older or in the presence of chronic stressors. And that can be compensated for by cannabinoid-based therapeutics and by modulators of the EC-bomb. So there are a number of things we can do to facilitate the expressions of new endocannabinoid receptor sites from both ends, using cannabinoid-based therapeutics and modulators of the EC-bomb to mitigate suboptimal or dysfunctional endocannabinoid signaling, which is then actually making cementing the word chronic to whatever condition ails you.
Very well put.
It's interesting because, this article talks about the efficacy and the risks, right? So they drone on and on about the risks of cannabinoids. And I was hearing what you were saying, Uwe, about the, using high THC at the beginning and then being able to taper down and then to add the CBD and all the different things that you can do. But they're really singularly focused on cannabis use disorder. And
it's to me, it's actually a scientific disfavor to frame it in this context, because even them using the word cannabis as to mean one cannabis is the same as any other cannabis, or all cannabis is the same, when in fact nobody goes to a pharmacy and assumes that there are 500 tablet types on the shelf, that they're all the same and that they're all used for one thing. And that's one of the biggest things I have with academia, because they don't even distinguish many a times between the chemotypes or between the difference of the effects that individual cannabinoids generate. And so for example, I know of a patient who had chronic pain and who was addicted to opioids. And what he started out with, and his map that he made in terms of how he cured himself of chronic pain and of the opioid addiction, is reflected in a great number of other cases that I've seen, and it follows roughly this map, or this territory, if you will. What he did is he actually started out with a concentrate, which I'm very sensitive to THC. If I were to take a concentrate, I would just have a panic attack, just because I'm very sensitive to THC. But for him, he needed a concentrate because he was on opioids for 20 years and he had chronic pain. So his threshold to strong drugs was extremely high. So to him, just smoking a little bit of cannabis wasn't even making inroads. But he noticed that when he would take to dabbing, that it would instantly take the edge of his chronic pain. And then what he did, he reduced the concentration of the product that he was using from 80 to 70 to 60 until he reached flower levels of about 30%. And so he managed to do that, and over time he brought the percentage of the flowers down. He brought CBD into the picture to the point where he was using 20 to 1, 10 to 1, 1 to 1, switching over to CBD, and then eventually bringing in modulators of the endocannabinoid dome and mind-body approaches. And so now he's able to manage with occasional THC dominant flowers for a flare up, or when he just needs it, and all of the other elements of flowing into the space that was being generated. And so it shows a journey, that you can downstep your percentage over time. And I don't know what your experience is along those lines, Debbie, but I've seen it so many times over and over again that, and the same is true with the opioid sparing effect. You can literally, reduce the amount of opioids that you're taking and balancing it out. You just have to sort of find a starting point. Is it 5 milligrams every 4 hours for you that allows you to reduce your opioid dosage by X%? And so there are some studies that are out there that begin to shine a light on what specifically those maps would indicate. And so it's nice to see, and again, when it comes to chronic pain, there's hundreds of different expressions on a spectrum, and we need to take them on a case-by-case basis.
I can 100% back up everything you just said there, because I had been on opiates for over 20 years, and I had been at 240 milligrams for a very long time. And the doctors swore to me I was not addicted, it was a dependence. And that's not true. It is an addiction, even though it was prescribed. I never took any more than they suggested. I never asked for a prescription earlier. When you start doing your detox and getting off of it, is when you begin to realize this. And that's a whole thing that's not really covered in this study, and how getting off of opiates and how to manage it with cannabis so that you can do that. And we don't talk enough about the differences, as you were talking about, when we start evaluating all this study and the people that were in this study, and understanding the level of their pain, how long they'd been on opioids, and then how long they had been using cannabis. And we end these studies too soon, because we follow them for 6 weeks, 6 months. And if you're a true chronic pain patient, especially if you live with CRUPS, complex regional pain syndrome, it doesn't go away. We're not curing it. It's just there, and we have to continue to manage it. And so I think that's one of the biggest mistakes we make in all the studies for chronic pain on any medication that we look at it for, is that we think that it's just going to handle it. The difference between cannabis and opiates is cannabis opens up and responds with your receptors, where opiates dull you. I can guarantee you 100% it affects your ability to think, to process, and to communicate. I got to the point you could ask me a question, where do you want to go for dinner tonight? And I couldn't even figure that out. Started using cannabis and all that changed. So these are the things that are never in these studies that we don't address.
Wow. Thank you for sharing that, Debbie. And it's the quality of life is a huge component here, but they also talk about, the opioid epidemic, and then they talk about the economics of it, right? And so the cost of opioid addiction, and they said economically the epidemic has imposed an estimated staggering annual cost over $1 trillion in the United States every year. And they said that including the cost from healthcare expenses, loss of productivity, criminal justice, social welfare interventions, reduced quality of life for opioid use disorder, and life loss due to fatal opioid overdoses. And
to me, that point is the biggest one, because I don't care if we spend $1 trillion if we help people get better, but in the same context, there's 70,000 people that die from opioid related overdoses on an annual basis. That's a stadium full of people. That's Berkeley Stadium up in the hills, filled to capacity. On every year, die needlessly when there are other better methods at our disposal. And that cost is really the what boggles my mind.
Yeah. And there's 6 of us here on the call, and I'm sure that probably half of us actually know somebody that's died from an overdose. I mean, my nephew did. He struggled.
My cousin did.
Well, and if you've ever lived in chronic pain and you're struggling to find help, you don't understand what that is until you're there. I know when my doctors stopped treating me and said, okay, because of the opiate crisis, we can't help you anymore. We'll not give you any more prescriptions. I was in the hospital fighting for my life because I could not breathe anymore, because I have lung issues on top of everything else. And so, that's not how we treat a patient. And so you can't feel my pain. I'm sorry you can't. I'm not sorry you can't feel it, but I'm sorry you can't feel it to understand what it feels like to be in this place. Because there is a desperation, because you get to the point, why should I want to live this life? I've been there, done that.
And when we look at this context of the opioid crisis, the thing that also needs to be made clear that opioid is a lifesaver, is an essential tool in a healer's doctor's bags. It's a must-have. If I have a wisdom tooth extractions, I need some opioids to hold me over for 3 days to manage the acute. And that is amplified by 1,000,000 for anybody who has severe pain and chronic pain. And so it's complex and it's patient specific, and it's not to throw out the baby with the tub water. It's just that we have a lot more tools available if we bring in endocannabinoid medicine into the mix. We can reduce risk, we can induce opioid sparing effects, and we can support optimal endocannabinoid signaling and analgesia, effective analgesia. And it just needs to be titrated on a weekly, monthly basis to make sure that we always adjust with the shifting needs of how the patient presents from one day or 1 week to another.
Agree. We need to learn to use plant medicine first and foremost when we are talking about anything, and if that doesn't work, then we move on to the next thing. But yes, when you have major surgery or something that is going to put your system in total shock, basically, then in the pain that it's going to be in, you need that extra. But that doesn't mean you continue it.
Yeah, exactly. And the thing is, they are both plant medicine. Everything we're talking about is 2 plants. No matter if we're using synthetic versions or not, it's like humanity has had these healers, at our disposal for tens of thousands of years. We figured it out early that making a tea of poppies is help with pain. Same with cannabis, for the same reason. Every materia medica, that's ever been written includes both of these plants as a foundational remedies.
And this article does talk about the history, which I think is interesting. In the abstract, it says regulatory barriers, including the classification of cannabis as Schedule I substance in the United States, continues to hinder robust research and clinical integration, right? But then, like a couple of pages down, it talks about the history, and it says that some of the earliest recorded uses date to 1900 BC in China. It talks about the papyrus from Egypt, written around 1500 BC, which discusses the topical application of cannabis for inflammation. Similar writings from the Roman Empire document the analgesic and anti-inflammatory properties of cannabis in treating ailments. And in the early 1800s, Dr. William O'Shaughnessy, a surgeon serving in India, published a medical pamphlet describing the narcotic and psychoactive effects of hemp in various forms.
And learned it from the traditional healers in India.
Exactly. And then it says, following this publication, cannabis became widely available as an over-the-counter medication in Europe and the United States. In 1890, Sir Russell Reynolds, who would later preside over the British Royal Society of Medicine, promoted the use of cannabis for migraines with patented marijuana tinctures readily available. And then in 1906, the Pure Food and Drug Act mandated that regulations of labeling and dosages for medication containing cannabis, cocaine, and morphine. It was then removed from the United States Pharmacopoeia in 1942. So you were just saying this, like, this isn't new, but here we sit today where this research is saying, oh, we can't do research, we don't really know because it's Schedule I, and it's a cop-out, it's like, no, we know. The history tells us this is good for pain. So anyway, and then it talks about the different types of pain, which you were speaking to. Debbie, in this particular article, they cover fibromyalgia, headache, cancer-related pain, multiple sclerosis, musculoskeletal pain, and then they do kind of, touch on the opioid sparing effects of cannabis.
And I think it's also important that we think about that nothing that was mentioned there were any of the cannabinoids that can really help beyond CBD and THC, because there are cannabinoids that can add benefit beyond that, especially CBG with inflammation. I was on opioids for, like I said, over 20 years. It did nothing for my inflammation. But when I learned about CBG and started adding it in, that's when I started seeing even better results with managing my pain and taking care of it, because it was reducing my inflammation on top of everything else that it was doing. I still believe that a little bit of THC is so important to make sure your receptor is responding properly. Because if you leave that main mother car, I call it the mother car, receptor open, then the CBD is not going to perform as well if they're both there together. And I think that's, again, something that was not brought out in this article. Understanding why those are both so important and why we always need a little bit of THC.
I absolutely agree with you, Debbie. And the other thing that I wanted to throw into the mix here, if inflammation is part of the underlying pathology of the chronic pain, then any modulator of CB2 is going to be extremely helpful. And I want to especially point out beta caryophyllene, which is a pretty strong CB2 agonist. I believe it's about 1/3 the strength of THC at the same receptor site. So you can take it internally, or you can apply it topically, and it can make a big difference, especially if you combine it with a little bit of THC or whatever amounts of THC you need, CBD, CBG, and a number of other modulators of the endocannabinoid dome. The other thing I wanted to throw out there, they're finding out that adding turmeric to your diet induces the body to code for larger numbers of CB1 and CB2 receptor sites, which then allow you for lower dosages of cannabinoids that bind with these receptor sites to induce effects that have longer lasting and stronger effects than without the additional expression of those said receptor sites. And we're not just talking CB1 and CB2, but we're also talking about TRIPS and PPARs and a number of other neurotransmitter signaling pathways that are also modulated by these various cannabis constituents that can play a significant role in the modulation of chronic pain, no matter what underlying pathologies is contributing to it.
One of the things in this article I did find interesting, it's like on page 16, and it talks about the guidelines for physicians. And I hadn't always seen that in research where it actually gives guidelines to physicians. And I thought that was interesting because you have your guidebook here. But it talks about guidance for physicians on the safety of cannabinoids compared to other analgesics. And the first one they talk about is opioids, and that's pretty clear. Cannabinoids, 0 deaths due to overdose. Opioids, way too many. But then the next one that they talk about is like NSAIDs. And so I kind of want to, I don't want to say Tylenol. Like, I'm so afraid to say acetaminophen or Tylenol right now after what's been going around in the news the last couple of days. But I mean, cannabis is safer than Tylenol.
It's metabolized in the liver, and what? How many hundreds of deaths do we have annually because your liver failure associated with Tylenol alone?
But they also talk about the comparison with like gabapentin and things like that. And I did want to read this because I loved it. I was so happy to see this in research. Physicians should take a patient-centered approach when considering cannabinoids, assessing individual pain conditions, comorbidities, and potential drug interactions. And I think that's kind of, you had already stated that, Uwe, and you as well, Debi, that really it does depend on the patient, that we have to look at not only pain, but most diagnoses and most things that are going on, really this patient-centered approach is the way to go, because everybody is so different.
Well, to manage pain is just not one thing. And when we said that earlier, it's a whole bunch of things. It's diet. It's how you think, how you focus on it and don't focus on it, how you handle yourself with it when it's at its peak, and what you do to bring yourself, back into some form of place where you can cope with it. And it's also being able to communicate that with whoever's helping to take care of you. And that is not an easy place for people today to talk about their chronic pain and how can we manage it, how can we address it due to the opiate crisis, and where that's put so many patients and put them on the outside with no one really listening to them or helping them for the most part. So, it's not just one thing that helps manage chronic pain. And I think that's something that I wish more studies would look at, is the overall everything that needs to take place. Going back to gabapentin, I don't know if y'all saw this. I did my fair share of gabapentin pushes through trial experiments trying to get rid of my chronic pain. And that new study that came out, I've read it. It's just one study, but how it's showing that it causes Alzheimer's. So, we don't find that with cannabis.
No, the opposite, in fact.
Exactly.
I have to talk a little bit about the potential risks and what you said at the beginning, Uwe, about you feel that this article is a little bit too conservative. They always really kind of like, I don't know if it's beating the dead horse or what this is, but they keep talking about the cannabis withdrawal syndrome. They talk about how those symptoms include irritability, insomnia, restlessness, hot flashes, and cramping. I just wanted to ask you, Debi, talk to us about the difference between a cannabis withdrawal symptom and an opioid withdrawal symptom.
Well, I can tell you I've never had a cannabis withdrawal symptom. So I can tell you that I've never had to face anything like that. Even, I might consume 2 times today, where I used to consume consistently when I was going through my reduction so that I could reduce my opiates. There was never any withdrawal. Withdrawals from opiates is intense. It's something I would never want to wish anybody on. I had worked through detox centers before at the hospital. Didn't fully understand what that process is. I do now. There's nausea, there's sweats, there's vomiting, there's diarrhea, there's lack of sleep. You want to physically crawl out of your skin and not exist. It is intense. Cannabis helps to make that not be so intense. Thank goodness. I can't imagine having to do that without that. And I look at all those patients that I used to have and think, what are we doing to these people? This is not the way we should be handling detox, period.
I agree.
It is wrong. We have tools on the table that can help make that process easier. I went from 240 milligrams a day to 190 in one swoop with serious chronic condition of breathing on oxygen and was put in the hospital. And that is not the way we treat this. It needs to be done in a more gradual fashion, especially when somebody has serious health issues. There was no thought or concern about my health. It was, we're in the middle of the opiate crisis and you have to get off of this. And that's not how we address this. And how do we expect a patient or a person to not go back to that when they get out of that situation?
It's barbaric and non-helpful.
It is not helpful. It's very destructive. So, there's just no comparison between cannabis and opioids and what it does to your system. And cannabis is nice to my system. Opioids, I cannot say they helped me control my pain, but I was still at a pain of 10 at 240. So was it really doing its job? I don't know.
Well, it's typical of orthodox medicine, to when the environment is full of fear of lawsuits than to act from that fear and have the pendulum swing the opposite way and then go, sorry, can't do that, go cold turkey. I'd rather have you suffer than me take the vulnerability of legal liability. And so that is bred into the system. That's a personal liability for each prescribing physician. That is understandable, but it also leaves too many people going cold turkey with no resources when in fact we have safe alternative that can make that transition so much easier and so much more elegant, as you just perfectly described from a first person position.
Well, I can remember sitting in my doctor's office and him saying, and it was just a regular wellness checkup for the year. So I went in for that. He said, I'm letting you know I cannot prescribe your opioids anymore. And I'm like, why? And he said, an office policy change. This was the reasoning. And I said, why? And he said, well, because you might drive. I haven't driven in years. I quit driving in 1995 because I took the responsibility to not drive because it affected my ability to think while I was driving. So you don't have to worry about that. My husband has brought me to every single appointment. He's been here by my side. You know that. So now why? Well, because you might not use it properly. I've been using it for years. I have never asked for a new prescription. I've never told you I lost one, and I've never asked for another pill. So why? And he says, well, I couldn't convince anybody that you were a good person. So I have to follow the policy.
Yeah, but he's really saying we are afraid that we're going to get sued.
Exactly. And he said, and I don't know who will help you.
Right.
And it's like, okay, so where does the patient tab? I trusted you to be my sole advocate, basically, in this position. And where does that put the patient? And where does that put the patient's family? And what are they supposed to do if no one? And I saw countless doctors trying to get help. I saw countless pain doctors to get help. It wasn't happening. The only thing they would tell me is, if you can get down to 90 milligrams a day, we might help you. Okay, give me a prescription for 90 milligrams a day. Oh, we can't do that. You know why they can't do that? Because they knew what would happen. Taking me from 240 to 90 was not safe. So where are you leaving patients in those situations? So it's like,
it's to me, it's a travesty that the federal government isn't stepping into that void and providing the best possible, least harmful strategy forward based on the information we have. And we have the information, even though many of the studies, including the one that we looked at today, are saying there isn't enough study to make informed decisions when it comes to opioid sparing strategies. I disagree with that. There's enough information out there, especially with the safety protocol being what it is. I mean, with the safety profile of cannabinoid-based therapeutics the way it is, there is a pathway forward. And I'm just echoing what you're saying, Debbie, and I find it horrific and barbaric and a travesty that there isn't more leadership from the top down. And so, we have to do it from the bottom up. We have to educate ourselves and educate the people we work with, and help in whatever way we can in providing that map to fill that void. That's why we wrote that book, with the hopes that it can provide, we created 8 particular pathways, to fill that void, to manage that void, no matter where you are on the spectrum of extreme versus minor chronic pain. And so there is discernment, and all of the things are evidence-based. Maybe they're not 20 double-blind studies, but if there are at least 2 with a n number of 100, that's actionable data, especially with a good safety profile of what we're talking about. And so it's there. It's just that in we still have the narrative on the war on drugs affecting too many people in power, making choices based on fear, based on liability, based on being sued. based on creating more problems than it's worth. When in fact, if you look at it, there is information, there is data. We can chart a way that's as safe as possible and provide a map for people to transit through that dark valley of the night, if you will, if you allow me that metaphor, that people who are hooked on opioids are going through when they're having the symptoms that you described, including this horrific dysphoria, which to me is the worst. And so there are ways. So let's look at them. Let's point them out.
Well, and one of the things I was thinking about when you were talking, I remember 10, 15 years ago, I would have these patients come in and say, Heather, I'm reducing my number of opioid medications with the use of cannabis, but now when I go to my pain doctor, they're drug testing me. And if I come up positive for cannabinoids, they're cutting me off. Help, what do I do?
I mean, how is this not insane,
It's not humane.
Yeah, that's for sure.
It's not humane to put a person, I'm lucky that I'm a strong person and that I was willing to go to fight. I mean, once I could breathe on my own again, I made a promise I would do everything in my power to educate on this and make a difference, so no one has to do this. But not everybody has that ability. Not everybody has the family behind them to do that. And this is what the society does not understand. And this is what the medical system does not understand. Because once they wipe their hands of this, they close that door. Doctors don't even ask me about my pain ever again.
They're not interested, nor do they have the time. And it's fraught with risk for them. And so why would they? They're the personal risk to them. There's very few doctors that take the time to connect with the patient in that space in a way that's therapeutic through time. They're very few, far too few in between.
Well, and I get it. I mean, I understand doctors are afraid of losing their license. And I say today, that's the best thing they ever did to me is abandon me. Because look where I am now.
You hit rock bottom and you pulled yourself out and you came out on top stronger.
Right. You have to realize I had a 24-hour caregiver then. I wasn't even caring for myself. Right. So, sitting here doing this today is truly remarkable.
A team effort.
And so it's, but it took me having a support system to where I could do this. Right. And there's so many people when they live in chronic pain, their family walks away and leaves them, and they don't have that.
Here's the other thing that what Debbie, you just reminded me of. Remember the case I gave you with the chronic pain heroin addict that tapered off after using concentrates, right? What they found comparing case studies of similar patient population is that those that succeeded through that shift towards healing had a support system. Those that didn't have a support system failed 95% of the time. So a support system is as essential as any step of those things that these people that succeeded, from using concentrate down to flower, down to 1-to-1, down to into the endocannabinoid dome, and then just occasional use. Those that followed that map, virtually all had a support system of substance.
Yeah, it's critical in this space for sure.
I'm so glad you made it through, Debbie. Just listening to you, I was thinking about my nephew who I grew up with. I was 5 years old when he was born. He was like my little best friend, a wonderful person, beautiful artist, an amazing human being that got caught up in this mess, and when the doctors cut him off, he went to the streets looking for things. That created a whole nother set of problems. he detoxed in prison. Couldn't continue
Oh,
that,
sure.
so
Yeah.
started whatever they do in prison and wound up with hepatitis. And I mean, it's this road to hell, literally, for so many people.
And living hell, absolutely.
These are
It
not
is.
bad people. These are people who have this medicine, opioids that just take a hold. And thank goodness that we have cannabis. Thank you, Uwe, for writing this book and giving a tool to people. Thank you, Debi, for sharing your personal story. And it's, I'm grateful.
Well, thank you for giving me a space to share it, because I think it's so important that people understand these are human beings and they deserve to be treated better. And if you've never lived in chronic pain, whatever level it is, you don't understand. It's easy to make assumptions, to draw conclusions, but when you cannot walk in their shoes and have not been there, you do not understand. It's always like having the pain that I live with is always like there's a stranger in the corner tapping me on the shoulder, always saying, "Is it today? Are we going to finish this today?" It never left me until I found cannabis. And so, knowing that there's something out there that could help every single person, it's important. I think there should be a cannabis clinic on every corner where we have a methadone clinic.
Here, and that is to me a very worthwhile map to repeat. Instead of methadone clinics, or adding to the methadone clinics, a cannabinoid-based therapeutics, including cannabinoid-based therapeutic protocols, and the other thing I wanted to throw into the mix, that whenever you have chronic pain, there's always a mental emotional pain that goes with it, and maybe is even underneath it, and the combination of the physical pain and the soul pain, if you will, is just horrific. And the way we treat these people is as outcasts, as pariahs, as undesirables, as troublemakers, as thieves, and I mean, so many names being thrown at them, when in fact they are people who are in significant amount of hurt and pain, and they need healing, not prejudice.
Well, telling someone it's in their head, they don't really have pain,
How is that helpful?
or just get over it, it'll go away. It doesn't work that way.
That's poor bedside manners is what I call that.
Exactly. So,
That's someone that does not need to be seeing patients. They shouldn't even be in the profession to
They
say
should not
anything
love.
like that.
yeah. But thank you for giving me this opportunity to share this story, and hopefully it will help someone else see the way that there is another option, and maybe another family member will hear it and can share it. But finding yourself in prison, I can speak from a personal standpoint with my son, is not a place for we rehab people.
Definitely not. Thank you so much. This has been really enlightening, and I appreciate you being here, Uwe. I always say this, I mean it from the bottom of my heart. What you bring to the table, what you bring to the world is so beneficial. Thank you for sharing with us.
Thank you. Feels nice to hear.
Very nice to have you here.
Thank you.